Thank you. It's great to be here. A little bit of a rush. Just came over from the OR over in our Bloomington office. But I'm going to speak for a bit on some management decisions we make in glaucoma care. And I have a bunch of videos. In the first video, I'll want audio. And let me know if I need to do anything from it up here. And if it doesn't play back, great, that's fine. So here are my disclosures. I have the privilege of working with a lot of the companies that are trying to develop better technology in glaucoma care these days. And as a speaker, I usually like to have kind of an underlying theme that resonates throughout the talk. And in this one, you know, I would say I really love what I'm doing right now in glaucoma anterior segment surgery. And so it's really a lot of gratitude for the innovations that have happened, and gratitude for colleagues and organizations such as this and the others that I work with, and really our industry partners. And I was at the Glaucoma Research Foundation meeting in San Francisco recently, and there was a patient that spoke at the fundraiser, and you'll get a sense for the plea for help in his testimonial. But really what he said was really, I think, it resonated with me because of, for the last 20 years, we've been working on different ways to refine glaucoma surgery. And so I'm just going to play his comments. It's Philip Van Leer, who's a well-known actor from the series Prison Break. And so I got to meet him, and we spent a lot of time talking about his glaucoma. But we'll see if this comes across, if the quality is okay on his audio. I'll turn up my own speaker here.
I think every glaucoma patient will have that moment, that crystallized moment when they say, something isn't right. For me, it was the year 2000, sitting in the box seats at Wrigley Field, watching my beloved Cubs. The notice.
So is it coming through? Oh, good. You guys can hear it okay? All right. I'll put this back on. And so he's talking about when he was first, sitting in Wrigley Field.
That moment, that crystallized moment when they say, something isn't right. For me, it was the year 2000, sitting in the box seats at Wrigley Field, watching my beloved Cubs, and noticed that the left limb seemed just a little foggy. I was diagnosed with open-angle glaucoma.
And it's okay if it doesn't come through.
You can go to settings and select this as the sound output. Sorry for the interruption.
Yeah, and it's probably
I'm not even an
that.
optometrist.
Maybe you want to do it?
Yeah. Let's see, sound output to decimator. That should fix you up nicely. Let me turn it down because it may blast.
Yeah, it's a good idea.
We can hear it pretty good.
Can you? All right, and this will be our last effort if it's not adequate.
I think every glaucoma patient will have that moment, that crystallized moment when they say, something isn't right. For me, it was the year 2000, sitting in the box seats at Wrigley Field, watching my beloved Cubs, and noticed that the left limb seemed just a little foggy. I was diagnosed with open-angle glaucoma in 2000, but thank God nothing really changed. I was able to continue with both the coaching career and the acting and directing career. In 2015, that changed dramatically when my diagnosis went from just open-angle glaucoma to acute end-stage glaucoma. Well, that altered my life, both as an artist, as a husband, father, friend, grandfather, and as a coach. Glaucoma, though not a death sentence, is a life sentence. For me, I think it's just the loss of what I was so used to seeing around me. the contrast between the blue of the sky and the green of the trees. On a very personal level, of course, I miss seeing clearly the faces of my family, my wife, my bride's beautiful face, the faces of my children, my grandchildren. I would not be completely honest if I didn't say that there are moments with my wife and I where we weep over the sadness, just over the heaviness of losing my sight. I've had 7 surgeries, 2 on my left eye, which is now completely no vision at all, just gray, and then 7 surgeries on my right eye, where I have about 3% vision left peripherally. At one time, I believe I was taking 9 drops daily. Disease knows not stature, race, creed, color, nationality. Glaucoma is a human disease. It touches everyone. There are so many people out there that are in this fight with me. That's you, Big Pharma. That's you, medical professionals. That's you, lobbyists and legislators. That's you, medical social workers. That's you, venture capitalists. That's you wanting to make a change, wanting to leave a legacy. Please be encouraged. We want that. As a glaucoma patient now for 22 years and hopefully longer, we want you to be excited about it. We want you to be all jacked up about finding a cure. If I could say anything to you, is just think about that. With all the challenges, with the pitfalls, the disappointments, the setbacks, the future is bright.
So we don't need any more volume on any of the other videos, but the reason I played that is I love taking care of patients like Philip, people that are hanging by a thread, that are on their last bit of vision, and that's a significant part of my practice, but really the vast majority, the overwhelming majority of glaucoma patients are proximal to that, people with more mild disease, often asymptomatic disease, and our charge is to prevent people from getting to the stage that Philip is at, and that's partly why I'm so excited about our field, because I think we've got such dramatic improvements in recent years, and it's reflected on fellowship applications. The glaucoma fellowship applications are way up, and some of the other major fellowships are flat or slightly down, and I think there is a palpable enthusiasm in our field, and much of the reason for that is the advances that we've seen with minimally invasive surgery. And I used to say that the MIGS mindset, and by the MIGS mindset I mean that safety is as important as efficacy in glaucoma surgery. For most of my training, it's like, well, if it doesn't work as well as a trab, why use it? And because it's a lot safer than a trab. And I think that mindset has really permeated through our field and is well accepted now, that safety is every bit as important as efficacy. And I used to say in the management of cataract and glaucoma, because that's where really MIGS was born, but I changed that to surgical glaucoma, because it now applies to really all of glaucoma surgery. But frankly, I've changed that to it's critical in the management of glaucoma, because it's affected everything about how we manage glaucoma today. We've got way more surgical options, we've got safer surgical options, we've got earlier opportunity to intervene surgically. We see now less medication toxicity because we're not driving people to the point of toxicity before we intervene. And improved quality of life for patients for sure, but frankly, significantly improved quality of life for us too, because I don't lay awake at night nearly as much as I used to with some of the real tenuous procedures that we might subject patients to. So a common audience response question, this isn't one for this audience, but a common one that I ask when I lecture is, when you're starting therapy for glaucoma, your initial treatment, are you recommending eye drop therapy? Are you recommending laser therapy? Or do you present eye drop therapy and laser therapy as neutral options? And years ago, it was almost always number one prevailed. often number 3 prevails, meaning, well, I talked to them about both and let them decide. But you could make a strong case, a very strong case, that number 2 is really the most appropriate response these days. And mostly that's based on the light trial, and I'll talk about that in just a second. But we've known about the pitfalls of medical therapy for some time. Not to really underestimate how important pharma is in managing glaucoma. It's critically important, but the pendulum swung way too far toward medicines, and I think the light trial has reflected that, and we know the shortcomings of topical therapy for glaucoma. And I think there is an interventional mindset that is present in our field right now and is becoming pretty mainstream and widely adopted. Now, this slide is probably aspirational, that we could get to the point where the bottom statement might be true, that we use topical therapy like we use Diamox today, for example, as bridge therapy between more interventional-minded things. So we might start, the legacy treatment paradigm is medication, additional medication, maybe laser, filtration surgery, and more filtration surgery. That's kind of and then maybe cilioablative surgery at the end. But the new standard perhaps might be SLT, then maybe a drug delivery option, maybe MIGS, phaco-MIGS, and using eye drop therapy in between interventions as bridge therapy. And I think a lot of people are looking to that as the future. And the basis for that, at least now, is the light trial. And the summary in the Lancet, for those that aren't aware, is really a top-tier journal globally. New England Journal of Medicine's kind of our, and when I say medically, it's like a New England Journal of Medicine in that it's all of medicine, not just ophthalmology. It's actually quite unusual to get an ophthalmology article in Lancet. And this was published in Lancet, very high-quality trial, prospective randomized trial. And I'm sure you're all familiar with it, and I'll show some of the summary findings in that. But then a follow-up pertaining to SLT in Lancet as well. The light trial compared eye drops to SLT for the initial treatment of glaucoma. This trial, the second one, compared SLT to timolol specifically, and SLT was superior to timolol. And what's unique about this study, unlike the light trial, which was a high percentage of early glaucoma, ocular hypertensives, mild glaucoma, this was 74% severe stage glaucoma and 24% moderate stage glaucoma, and SLT was effective in that population, superior to timolol. And this is a busy slide. You don't have to look at it too carefully, but it's just more of a kind of a theme in the NICE, which is the National Institute for Health and Care Excellence in the UK. So that's what governs the public health system, came out, and their recommendation for the initial therapy for glaucoma is laser. It's not, don't offer it, you recommend it, and then you do drops for those that SLT is not suitable. So in the UK, that's a recommendation. In the European Glaucoma Society, it's also a recommendation that laser be done first for most patients with open-angle glaucoma. Tony Aurelini spoke at our state society meeting recently. I couldn't attend, but I listened to his full talk online. And he had some really interesting points, and we know this, but it's well said the way he said it. For most patients, the only symptoms of glaucoma are from therapy. And I think that is true. For most patients with mild to moderate glaucoma, their only symptom is what we're doing to them for the most part. And there are no immediate incentives to take glaucoma medications, only disincentives. And that partially explains some of the reasons that compliance is poor and medical therapy fails so often. So some of the summary bullet points from the light trial. 70% of SLTs, remember this is a prospective randomized comparison, a large trial comparing laser to eye drop therapy. 70% of SLT eyes remain medication-free and at target after 6 years. Now, we all might say, well, gee, I don't see that. But we don't do laser the way they did. We don't typically do it as the first intervention, or at least if we do, it's a recent development. So 70% remained medication-free and at target at 6 years. and they did allow retreatments, by the way, less glaucoma progression, fewer trabeculectomies, and lower cataract surgery, statistically significantly better in all three of those parameters with SLT over eye drop therapy, and by a wide margin. If you look at the trabeculectomy rate in the SLT group, 13 eyes versus 32 eyes in the eye drop therapy group, and cataract surgery, astoundingly different, 95 eyes in the eye drop therapy, 57 eyes in the SLT group, which certainly begs the question, you know, does eye drop therapy, is it cataractogenic to some extent? No serious laser-related adverse events. So you can make a strong case that laser should be recommended as the initial treatment for most patients with open-angle glaucoma. Now, if we go from laser and eventually need something more, we do have better drug delivery. I think intracameral bimatoprost is probably underutilized. Does anyone use much in the way of Durysta? That's actually the last thing I did before I came over here was a bilateral Durysta implantation, and I like it for a lot of reasons. Now, when I poll audiences if they're using it or not, the most common reason that they might not be is because one of my options in my sequence of options is if one and done, why bother? Because as you may know, with FDA labeling, it's on label for a one-time use. And that's because we were part of the trial, and we put in 3 sequentially, 1 every 4 months, which I don't think we need to do. But they were concerned about the corneal endothelium because the first one was still there when we put the second one in, and they stacked a little bit and were a little bit more prominent in the angle. But with a single dose, it seems quite safe. And some people do redose even though it's off-label. A lot of things are off-label that we do. If you think in your best judgment that it's okay for the patient or a good option for the patient, it's perfectly fine. And in general, it's getting covered, at least in a lot of insurance regions across the country. So it's not necessarily a one and done. You can use your judgment and provide a second dose later. You just have to advise the patient it's off-label. But remember when prostaglandins came out, they were not on label for initial use. They were after other drugs had failed. And we quickly, once it gets in physicians' hands, you treat it in the way you think is best for the patient. So intracameral bimatoprost, a very straightforward. I do it right at the slit lamp. I do a drop of anesthetic, a drop of 4th generation fluoroquinolone, and a drop of proparacaine. Povidone, iodine, and just like we do in the OR, and just administer it. Very straightforward. In fact, I had a patient recently where I did sequential. I did SLT, and then 4 to 6 weeks later, our plan was to do a Durysta injection. And then after I'd done both, I said, which was harder for you, or more difficult? And she said, hands down, the SLT was more difficult because this is a very straightforward thing that we can offer our patients. I like it for elderly and infirm that have a hard time getting drops in. And I remember when my dad was in assisted living, they charged for every medicine that was administered. So there are times when it might be nice to get people off medications. And the young and busy that don't take their medicines when they go on trips, I think it's nice as well. Then this one is, this is intracameral travoprost, which is going to be available as iDose. The PDUFA date, that is the date that the FDA has given Glaukos for an approval word, is December 22nd, 2023. So we'll know by the end of this year if it's approved, and certainly the belief is it likely will be approved. And while I tell patients getting Durysta, they might get 4 to 6 months, or maybe they'll get a year from it. Some of these patients with iDose get up to 2 and 3 years from a single intracameral delivery, as you see there. So a lot of options for drug delivery, I think, are in the pipeline, and some good options for laser as well. So this is a Direct SLT. Has anyone seen the Belkin Direct SLT? So this is not yet approved by FDA. It's currently in regulatory review, but Direct SLT, the DSLT, comes right on at the limbus. I'll show you it being delivered in just a second. It's available in Europe. Most of the studies have been done in Hungary. I'm on their advisory board. But with SLT, we're going tangentially through a gonioprism. This is going straight on, thus the acronym DSLT, Direct SLT. And here's how it looks from the physician's perspective. You type in all the information you want. Very nice platform. It's got a registration that will identify the limbus, and the physician determines that it's in the right place and will activate the laser, and in about 2 to 3 seconds it'll treat 360 degrees of the trabecular meshwork. And it's been studied and found to be not inferior to SLT for the target population, patients on 0 meds or 1 med. And here you see it actually being delivered to a patient. And so it takes gonioscopy. Obviously, I'm never going to understate the importance of gonioscopy, but at least for delivering the laser, it doesn't require a gonioprism. Better for doctors and for patients, and I think a nice advance. How about a non-incisional goniotomy, where we can create a goniotomy without going to the operating room or using incisional techniques? I presented at both the American Glaucoma Society and the ASCRS meeting this year on the FLIGHT trial, the first in-human non-incisional femtosecond laser-guided or image-guided high-precision trabeculotomy, or FLIGHT acronym, and this is the first in-human pilot study, mostly looking for safety, but we also tracked efficacy, creating a 500 by 200 micron channel. So think of a goniotomy that we make with a dual blade or some other, an eye access or something that we're going to make a goniotomy, but this is a laser doing it without making any incisions, and it's using very high resolution imaging, as you can see here. And then here's the cartoon. So it's docking with a femto laser like you're used to with refractive or cataract surgery. In fact, it's the same core group of investigators that brought femto to refractive and cataract, now bringing it to glaucoma. And so you get this terrific image. And then here's the actual console. Let's see if that's, yeah. So you can pick any clock hour you want here based on what you're seeing here. You can rotate the camera, and then you pick your clock hour, and then it'll engage the laser, as you'll see here. You use OCT to gauge the depth and the location, and creating a nice, clean goniotomy, and you can do multiple. The FDA wants it simple and reproducible and standardized. So the trial that will be looked at by the FDA is a single 200 by 500 micron goniotomy. Like I said, non-incisional, and we've got histo up to 2 years, or at least high resolution, not histo. These patients are still alive. But we're high resolution imaging up to 2 years showing that they're still patent. And although this is a safety trial, we looked at efficacy and we're getting nice pressure reduction, but not enough patients to really discuss efficacy in great detail, but we're seeing a nice reduction in pressure like you would expect. And frankly, I would hope that these are more likely to stay open without any surgical trauma that we would induce with our manual goniotomy techniques. And this work was published in Ophthalmology Science, which is related to the Journal of Ophthalmology. As you know, there's ophthalmology retina, ophthalmology glaucoma, and now Ophthalmology Science. So a high quality, high standard journal that this work is published in. So now getting to things that we're currently doing, incisional surgery for glaucoma. So I'm still a proponent of trabeculectomy. It's what I use when patients are in the most trouble, but the good news is I'm doing fewer and fewer and fewer trabeculectomies these days because fortunately I think we're keeping more patients out of trouble. So although it's been the gold standard. Complications are too frequent, and they can be early complications, and they can be late complications. It can be a suprachoroidal hemorrhage that occurs during the surgery or post-op day 1, or it can be a blood-related endophthalmitis that occurs 10 years later. So early and late complications. And years ago, early in the MIGS era, I wrote an editorial that I felt that glaucoma as a field was getting a little too accepting of complications that maybe come with the territory. Well, that's glaucoma. That's really not the way it should be. I think in the past, we've just accepted that a certain percentage of patients are going to have a difficult outcome with trabeculectomy or tube shunts, and that is true. But we really needed to find a better way, and I think we're well on our way to doing that. All that being said, it's still, as the last sentence says, on the other hand, filtration surgery remains very well suited for patients at high risk for severe vision loss. But the whole MIGS mentality was not very well received early on. I remember presenting at the American Glaucoma Society the very first iStent data, and again, it was wanting to be compared to a trabeculectomy. Well, that's just not the way to look at it, at least in my mind. You're trying to prevent people from ever needing a trabeculectomy, not comparing it to trabeculectomy in terms of efficacy, because it would lose. It doesn't lower pressure nearly as well, but it would win overwhelmingly in safety. So it's that trade-off. And glaucoma management is basically risk mitigation. That's what we're doing. We're trying to mitigate disease risk, and we're trying to mitigate treatment risk. But there is going to be risk no matter what we do. If we get overly aggressive treating the disease and the patient has a surgical complication, that's not good. But if we undertreat the disease and the disease continues to progress because we're not aggressive enough surgically, then the disease risk prevails. So there's risk either side, but we just have to make sure we pick the right surgery for the right patient. Surgical risk ranges from the risk of being disappointed if an iStent doesn't lower pressure enough or SLT doesn't work well enough, to catastrophic risk. We see catastrophic risk all the time, unfortunately. Had a 92-year-old that I tried so hard to keep her out of the operating room, and we ultimately had to do, I did a Zen, which in my mind is a less aggressive trab, but she had a suprachoroidal hemorrhage, and I think she's going to get a good share of her vision back, but it certainly wasn't, we have catastrophic risk when we lower pressure as dramatic as we have to sometimes, because as I tell my 92-year-old patient, how do you stop bleeding if you cut your finger? Well, you put a lot of pressure on it. Well, exactly. These blood vessels have had a lot of pressure on them for a lot of time, a lot of years, and we had to relieve that pressure because your optic nerve was dying, but that blood vessel kind of liked that pressure, and it broke and bled. And so we see that. So the foundation, I think, of the MIGS development or the MIGS movement was the realization that cataract surgery lowers pressure. I'm absolutely convinced that it does for most patients, not all, but most. And we even had the courage, I think, to put the evaluation of a causal relationship between the natural lens and open-angle glaucoma. I do believe there is a relationship to this growing mass behind the iris that pushes up and I think maybe impinges on the trabecular meshwork. MIGS has been in development for a long time. I took my first Schlemm's canal surgical course from Bob Stegman in 1996. And this was an ab external approach. This is a 44-gauge catheter in Schlemm's canal and a non-penetrating procedure. There's no opening to the anterior chamber there. We've just unroofed the outer wall of Schlemm's canal. Now we go in through the inner wall. And then we used to peel off the outer wall, peel off the inner wall there, keeping it a non-penetrating procedure. I remember the first canal device I did was Ray Brown's iPass. I went down to Atlanta and did a bunch of pig eyes. And so this has been decades in development, but only recently have we refined it to the point we have now. I presented the data to the FDA for iStent back in 2010. By the end of the morning, we thought we were dead in the water. By afternoon, things changed and the panel voted it approvable, and the FDA approved it 2 years later. Just an incremental step. I think if it ended with iStent and we never got anything more than the first generation iStent, I think you know, it wasn't going to transform the field, but we've come a long way since then. A lot of the early work done in Armenia, and then the one thing I threw these slides in there because Denali Medical, which later became Ivantis, or at least spun off Ivantis, started it here in Minneapolis. I'm just going to go through these real quickly. So they called me back in 2007, said they've got this thing we're working on. We're in the cardiology space, but we think we have a Schlemm's canal device that's now become Hydrus. Some of the early things didn't look anything like the current Hydrus. We were working in the basement of the Philip Science Institute. It was 15 millimeters long at first, now it's 8. Used to be a 2 system, 2-person delivery. Someone would dial, the other person would put the device in the canal and they'd dial it in. There you can see the early things that we were using. Notes from our early meetings in 2007. Denali finally spun off Ivantis, hired a CEO and moved to Orange County. We did a lot of the early cases down in Tijuana. Like I said, a dual operator to a single operator, lots of different profile changes, and now is available as the Hydrus that you're familiar with, and I'll show some video in a minute. So what do I do now, and how do I minimize the risk that we talked about? Well, you know, first picking a procedure. We've got all these different options. You know, some of the obvious considerations. What's the status of the native lens? Is the patient phakic or are they pseudophakic? Are they +5 or -5 or are they emmetropic? All these things factor in. Their general health. You know, what's the velocity of these? Everyone talks about disease severity, but really the velocity of the disease is just as important. If someone has severe disease, but they've been stable for 10 years because they came in and their pressure was 35, and now we've treated them and their pressure is 12, and they're about to have cataract surgery, but their visual field hasn't changed forever, I'm much more likely to do a low-risk procedure on that patient. So it might be an eye stent or a Hydrus along with phaco, but they're severe, so it's off-label. Well, this is approved for mild to moderate, but you're severe, but you've been stable for a long time. I used to get questioned about that by insurance companies. Oh, you can't do Hydrus because they're severe. It's only on label for mild to moderate. Well, this patient's been stable forever. You mean I have to do something more aggressive than that because of some bureaucratic reason? I think we treat patients. We took an oath to treat patients, not CMS. So I think we do what we think is right and then justify it with a letter or some phone call to explain why you're doing it that way. Some of the nuanced things, what's their coagulation status? How long is their eye? A 28 millimeter eye responds differently to surgery than a 22 millimeter eye when you're lowering pressure. So I like to know all those different components. Are they going to need steroid post-operatively? If they are, maybe I need to do an outflow procedure like a Zen, although frankly I've used GAT quite a bit in steroid-dependent people. So as I mentioned, trabeculectomy is still my go-to for those at greatest risk, but I'm doing fewer and fewer trabs, fortunately, but I still do a couple a week probably. Maybe one trab a week and 2 or 3 tubes a week. It seems like I do a fair number of tubes because I've been in practice over 30 years now, and a lot of patients have scarred tissue because they maybe had previous limbal surgery or something. So anyway, trabeculectomy is best reserved for patients that have severe loss. So my guiding principles are the surgical risk should not exceed the disease risk. I believe in Murray Johnstone's principle that the canal is dynamic and pulsatile, not just a hollow static tube, so we want to preserve the canal function as much as we can. I prefer to retain normal physiology as much as possible. So I like stents, I like iStent, I like Hydrus for patients with more mild to moderate disease or even stable severe disease, as opposed to going in and stripping out the inner wall. And I respect hypotony as much as I respect high pressures. Those of us that treat a lot of glaucoma really respect hypotony a lot. And I like to take catastrophic risk off the table when faced with mild to moderate disease. So while there are exceptions, more often than not, I start with SLT, adding meds as needed. Surgical intervention typically triggered by the development of a surgical cataract, glaucoma progression despite a reasonable amount of medicines, or inability to administer medicines, or if they get surface disease. I'm gonna tell 3, right? Got a couple more minutes, is that right? Okay. Just to wrap up with a couple surgical videos. So for combined cataract and glaucoma surgery, I have the asterisk next to iStent, inject, and hydrus, because that's what I do most often. The ones at the bottom I do less often when I do combined surgery. I think you've seen all these procedures. One video on hydrus that I think is a common mistake that patients make. I believe you can thread the hydrus into the inner wall and have it get tangled in the inner wall. I have it paused here because you may not be able to see, but there's pigment in front of the hydrus here, but I know darn well I'm not where I need to be. Even though I see pigment in front of it, with a pigmented angle like this, the implant should almost disappear because you know you're behind that pigmented inner wall. You got to get back to the back wall or it's going to get tangled in the inner wall and deflect it a bit. So really do a little goniotomy. You can visualize back wall and then get all the way back to the back wall before you deploy it. For standalone, I tend to like GAT for patients that I can stay in the angle. I'll consider Zen, but I don't hesitate to go to trab or tube for patients with the most severe disease. And so here you see a GAT where I'm going to strip the entire inner wall for 360 degrees, which is certainly disruptive. So I don't really like to do this for mild to moderate disease unless I have to, if the pressure is really extreme. Or the patient who's a perfect candidate for this is juvenile onset glaucoma. I really like to do it in the younger patients. I think they respond beautifully to GAT. A lot of advantages of that over a transscleral procedure. No risk of blood-related problems, no risk of hypotony. And then Zen, I'm going to go right to my last slide here because of time. This is the way I'm doing Zen now, and this will be really my last slide. I do a traction suture off axis from where I'm going to put the device in because I want to be able to see the device entering the anterior chamber, and if your traction suture is blocking that, I inject my mitomycin, protecting the surface and irrigating anything that leaches out. I do it open now. This is, like I said, my 4th iteration. You can see all 4 at the top there. I used to do it ab interno, then ab external closed. Now I do it ab external open, again off label, but I think nationally that's what most people are doing. I'm really controlling the position of the eye. It went out of focus there because I was lifting so aggressively with my traction suture, because you absolutely have to control the eye as the trocar comes out, or the eye's going to rotate and flick and it's going to cut your device. The one thing that you may not be used to seeing here is I use the sheets glide to keep the device protected as I pull the conjunctiva forward. Otherwise, the device is going to get tangled in conjunctiva as you close. It's just so flimsy. And then I pull the sheets glide out as I close, but at least it protects it as I do this maneuver where you pull the conjunctiva forward aggressively. And I actually balloon up that subtenon space with both dexamethasone and viscoelastic. And with that, I've been pretty happy with my Zen technique. There's so many things to talk about, but that's kind of what I'm doing now. A lot of stents, and then I'll try GAT and Zen as standalones. I haven't done a lot of iStent Infinite yet. As you know, that got approved now for standalone use. Our local MAC is trying to figure out how they're going to cover it, but we are getting coverage. I'm happy to answer any questions. I'm not sure what you have next or if there's any time for that, but I'll leave that to you guys.
Do you have any trouble doing SLT first as far as insurance? That's been an issue for me. Since the light trial came out, I've been pushing it a little bit more first line instead of second line, but I get insurance denials a lot, and I don't have the motivation to write letters and
Yeah,
things.
I totally hear you. And it's the bane of our existence to some extent to have someone in an office somewhere saying, well, no, you shouldn't be doing that. When the data is right there, really. So I tend to get competitive about those kinds of things, and I can't wait to talk to somebody that was willing to talk to me about it, and they've always said, oh, okay, that makes sense, So, I think that's a fight we got to fight, and I totally get it, and maybe have a form letter or something that your administrator can send out or get the patient involved. But I think the science absolutely supports it.
Two questions. One, are you seeing much wearing off effect of iStent over time? And the second, those rare patients with glaucoma specialists who probably rarely see these people, the rare patient comes in, say, for cataract consult, does not know they have glaucoma, but they have glaucoma. And you put a stent in someone who's really not been on medications before, in terms of the effectiveness.
Yeah, so I think if a patient is either on treatment or should be on treatment, I tend to do phaco plus something, okay? And for that mild patient, it'd be iStent for me. I have this kind of strange question that I ask audiences sometimes. You know, let's just say everyone in this room, you may not have glaucoma, and probably very few do, but everyone in this room has to pick a MIGS procedure that they're going to have done to them. What would you pick? Almost everyone would pick iStent because it's so minimalistic, right? You've got 36 millimeters of canal. If you took Schlemm's canal and laid it on a table, it'd be 36 millimeters long. And each iStent is 0.34 millimeters, so you're operating on less than 1 millimeter of 36 millimeters. You're leaving 98% of the canal untouched or more. And so you're retaining that normal physiology, or that, you know, if this is normal and this is end-stage glaucoma, some people are just barely into glaucoma, and you don't want to do much, right? They're doing really well. You maybe want to get them off a med or keep them off a med. And so what I tell that patient is, you know, you have glaucoma, you need to be treated. Individuals just like you were randomized to cataract surgery alone or cataract surgery plus an iStent. And we had to change our mindset as how do we interpret this data. You know, there was a half med difference, right? And then you think, okay, well, that means if you have 100 patients and you do all cataract, maybe if everyone's on one med, that's one med, you know, outcome. And if the other arm, maybe half the people were off their meds and half had to take one med, you know, that's a half med difference. But half the people were off medications, right? So I mean, it's a meaningful difference, but it doesn't sound like a lot. But it might keep half the patients off medications. And so basically I said there was no difference in visual outcomes, there was no difference in speed of recovery, there was no difference in refractive outcomes, and the patients that got the stent were more likely to be medication-free or on fewer meds. And they say, oh, okay, you know, then you just do it. And then as far as coverage, I haven't had any trouble. Early on, yeah, sure, there was pushback, but I don't recall having any coverage issues lately in that sort of a situation. And I would say the same would apply to Hydrus, but Hydrus is doing a little bit more. You know, we have this debate all the time. Well, you know, which do you do, iStent, Hydrus, or KDB? I tend to be a stent guy. I was pretty involved early on with them, and so I may have that bias. But I also think it makes sense that if you have that mild patient, if I was that mild, either do cataract surgery alone or just do something minimally disruptive. Don't go to my prized entire nasal canal and ablate it, right? And now, for more significant disease, I think that's a reasonable thing because the data would support that. But when we're doing something that disruptive, I don't know what the 5-year, 10-year outcomes are going to be. There's got to be some kind of a healing reaction to that. But I do a lot of GAT, I do a lot of Omni for patients that are further down the spectrum and need something more, because I certainly would prefer that over a bleb forming procedure if you can get by in the angle, if you can augment physiological outflow.
I guess what I was getting at too is having spent some time abroad and working with a lot of glaucoma patients who come in never having been on medications. It's kind of a surgical disease in developing countries. I've had, I would say, at least a half a dozen patients in my practice in the United States who come in newly diagnosed glaucoma, pressures around 30. Cataract surgery, iStent alone, pressures dropped to 20, 19. First few times it happened, I told the patients, it's not supposed to work this well. And I've seen it, I probably am up to about a dozen patients now. And I wonder if it's the same thing. We saw that with trabeculectomies on patients who did not have medicines beforehand. We weren't using mitomycin.
Yeah, which is that slide I showed that, you know, we go from a pretty innocuous, where I say the risk of disappointment, I say that to patients all the time. What's the risk of this SLT you're talking about? Well, primarily the risk of being disappointed if it's not enough. I mean, I've not seen sustained vision loss from an SLT. It's been reported, you know, some endotheliitis type things that caused prolonged visual deficit, but I personally haven't seen it. So I've seen it not work for sure, but I've not seen a vision-threatening adverse event.
So one comment and then a question. I really appreciated how you spearheaded complacency with glaucoma outcomes and problems, complications. So I remember hearing that back in the day, and I was appreciative of that spearheading. So the question with the
DSLT?
DSLT, thank you. And the femtosecond laser, are there any increase in PAS or other issues like that?
No, not that we've seen. No. And nice thing about the femtogoniotomy is you don't get hyphema because, you know, we're used to seeing hyphema with goniotomy type procedures, but that's because we're dropping intraocular pressures subphysiological while we make it, so you get that reflux, but there's no incision, so the pressure never goes below episcleral venous pressure, so the flow goes the other direction from the start.
Over here, one last one.
Yeah.
Thanks. Do you think there's a number limit to the times the SLT should be performed, or just when it stops working?
Yeah.
And do you recommend using drops after SLT?
What was the last, do I recommend drops?
Do you recommend using drops
Yeah.
after SLT?
Yeah, so great questions, and I took these slides out. You know, I get so excited about a talk like this, I throw all kinds of content in there. There's never enough time to cover everything. But I had some slides on the COAST trial. So if everyone's familiar, the COAST trial is looking exactly at that question. You know, it's double randomization. It's low energy SLT compared to high energy SLT, or regular energy SLT. It's like 0.8 millijoules compared to 0.4 millijoules. So they're going to get randomized initially to that. Then at 1 year, they'll get randomized again to automatic retreat with low dose versus retreat as needed, like PRN if the pressure goes up. So what Tony Riolini, who's the principal investigator for this trial, is looking at is SLT something that should be done like on a regular basis, give a booster shot like you might with a vaccination, and maybe you can do that with low energy. So that question's being answered. And then Gus Gazzard, the first author in the LIGHT trial, will say that he believes his non-responders are inadequately treated. So he will look at someone who's not responded at 2 months and automatically retreat them with the belief that they didn't get enough treatment. They just need a higher dose. Whereas in the past, I've got a non-responder at 2 months and said, well, that didn't work, let's try something else. So that's all being worked out. And then your second question, should we use drops afterward? That's a mixed bag. There was a study out of Stanford called the SALT trial, steroids after laser trabeculoplasty, that suggested yes, anti-inflammatories may be a good idea, but there are a lot of non-believers in that, Tony Riolini being one of them, saying that the study design really wasn't qualified to answer that question because they didn't standardize for 360-degree treatment, 180-degree treatments, et cetera. And so he's a non-believer in meds. I typically do give him a non-steroidal for 4 days, 4 times a day for 4 days. I don't know if